DJI Consult Health Financing webinar where we discuss national, regional, international issue with regards to health financing. Thank you very much for joining. Uh, this episode will be discussing something very, very critical and unfinished business around reducing maternal and child health. And it became more important to discuss this, looking at the report released by UN Maternal Mortality Evaluation Interagency Group, which actually revealed a damning verdict about Nigeria, which shows that in the year 2023, Nigeria recorded the highest number of maternal deaths globally, and it accounted for 28% of global maternal deaths. The same year, Africa accounted for more than 70% of our global maternal deaths. Within the context of reduction in maternal death globally, the rest of the world actually experienced maternal deaths for like 40% the last 3 decades. But the same is not the story is not the same for Nigeria specifically and Africa in general. Against this backdrop, the government of Nigeria has introduced initiative as a response to this unacceptably high maternal death in Nigeria called Maternal Mortality Reduction Innovation Initiative called AMAMI. But against this background, we are going to look at what have we learned over time in terms of attempt towards reducing maternal death in Africa. We have a number of interventions that have worked, but the challenge remains how do we scale this intervention to ensure we have wide coverage? How do we implement this intervention to ensure we have a multiple intervention, service delivery intervention, system strength intervention, and community intervention coming together, including intervention outside the health sector. And again, how do we sustain the intervention? That has been the major gap in the attempts towards reducing maternal deaths, maternal and child deaths in Nigeria. So today we have assembled a number of experienced global health specialists. Um, we have assembled global health specialists, policymakers, implementing partner, and civil society experts to do justice to this conversation in terms of what have we learned globally and what are the pockets of successes that we have recorded in this in country and what have we achieved that we can use to do things differently. Joining me this afternoon, we're highly privileged to have Professor Charles Ame, who is a professor of global health at Liverpool School of Tropical Medicine. Professor Charles Ame has done a lot globally in terms of supporting, of course, his own country, Nigeria, and other African countries towards reducing maternal death and child death as well. Professor Charles Ame, we are very happy to have you. And also, we have a seasoned a policymaker, somebody that has worked very well in development setting and has been able to do a great job in his home state as as the Honorable Commissioner for Health in Ekiti State, and at the same time the chair of the Forum of our Commissioner for Health, somebody that supervised a success story around transforming the health landscape in Ekiti State. Welcome, Dr. Banji Afilani. Then we also have a very powerful lady who supervise great work that Clinton Health Access Initiative is doing in Nigeria. We are very lucky to have Dr. Olufunke Fashawe, who is the Vice President Integration Clinton Health Access Initiative. Then we are again very lucky to have somebody in the room, somebody that has previously served as the Honorable Commissioner for Health in those states, of course, implemented and supervised a flagship initiative in the state that was geared towards reducing maternal and child health, and he has received a global and national accolade for doing that. So we're happy to have Dr. Dayo Adeyanju. Thank you very much. I presently lead the MAMI initiative in the SWAP Office of Federal Ministry of Health and Social Welfare. Then we have Dr. Sachin Bukhari, who presently serves as health financing specialist for UNICEF in Nigeria Dr. Sachin is doing a great job in terms of looking at financing initiative towards improving child health in Nigeria. Then we have last but not the least, a very, very powerful health advocate, of course, somebody, a media group, but at the same time, the voice of the citizen when it comes to improving health. We're happy to have Chief Mojimo Kajuola, who is the chair of the Nigerian UAC Forum. To set the stage for this conversation, I would like to invite Professor Charles Army. What have we learned globally? This is the era of learning global best practices and adapting that lessons towards local initiatives. So, Professor Charles Ahmed, what have we learned globally in terms of reducing maternal and child health, and what should Nigeria learn from it? Over to you, Prof.
Thank you so much for inviting me. There's an echo there.
Please go ahead.
Yes, I'm just trying to get this right. Yes, can you see my slides without seeing my my notes? What can you see?
We can see the slide, but it's saying yes. Can you put it in slide mode or something? Okay, can you put it in slide mode? It's getting better. Presentation mode, I mean. Perfect, perfect. Please go ahead, Prof.
Okay, thank you so much, Gafar, for inviting me to speak, and I'm really privileged to be, part of this, very powerful panel of experienced health system and policy advocates and managers. So I've been asked to speak about crushing maternal and child deaths, adopting global lessons. And over the next 20 minutes, I intend to talk through several things, but just to say I have no interest to declare. All the data I'll refer to in this presentation are all publicly available data and information from peer-reviewed scientific journals and from other sources freely available on the internet. So I'm going to run through this outline. But I want to start with, just looking a bit closely at, we have a lot of slogans, and I think one of the ones around maternal mortality, especially in Nigeria, is the word crashing. And to help me understand what Dr. Gafar and team, wanted me to speak about, I had to just look for what exactly does this mean. And if you look at the Oxford Dictionary, I mean, the meaning of crash or crashing might be context specific. And it can be used in computing, a computer crashes, somebody crashing into a party, crashing can be used in sports, sleep, medicine, and all of that. But the definition which I found most appropriate for this was that related to finance and business, which is to lose value or fail suddenly and quickly. So what are our current values for maternal and child mortality, and what are the global targets? Some of these Gafar already alluded to when he started, but I will quickly run through them without taking much time. So I'll use the latest data available. So in terms of maternal mortality ratio, if you look at this heat map, so the key message to take home is that, the darker the country, the darker the color in the country you see, the worse it is in terms of maternal deaths. They have the highest risk of death during pregnancy and childbirth. And you see that our dear country there is probably amongst the darkest colors. If we move to under 5 mortality rates, the picture is similar. We are no better off. We're amongst the worst in terms of mortality. If we go to neonatal mortality rate, the picture is similar. If we go to under 5 mortality rate, the situation is the same. So this picture is really green. Now, where are we in terms of, so where do we, if we want to crash it from, the high values and the figures, where do we hope to land? And our guiding sort of indices will come from the Sustainable Development Goals. So where we are now, 2025, the SDGs will end in 2030. But this, what you have on this slide, gives us an idea of how far we have to travel and gives us an idea of the trends over time. So the targets are all there, 140 per 100,000 live births for maternal mortality ratio. So this is, country data. Global average will be 70, but I mean, 140 will suffice for our case in Nigeria. Stillbirth rate, we are looking at 10, 15 per 100,000 live births for neonatal mortality, 25 per 1,000 for under 5 mortality, and 13 per 1,000 for under 5 mortality rate. So if you look at these graphs, you look at the maternal mortality ratio, the trend for Nigeria, this really has not changed over the past 20 years. And there's a very interesting study, which I'll talk about, which really breaks this down for us. So if you look at where we are, over 1,000 from WHO estimates, in 5 years' time, if we want to get to 140, then this is really the definition of crashing. It's a tall order. Maybe it's possible. We don't know, but we're going to look at what we can learn from other countries. Stillbirth rate as well. If we continue on our current trajectory, we probably will go down just only 2 points by 2030. If we really want to crash it, then we have to take the acceleration needed to get there, which is indicated by the green hash line, and the same with neonatal mortality. So let's look at what works in terms of reducing maternal mortality. And I want to start here. I know probably I'm preaching to the choir at this point, but I just want to remind us about, this good old chart from WHO about health systems. We need a functional health system that delivers quality services to all people when and where they need them. The exact configuration of the services will vary from country to country, but in all cases requires a robust financing mechanism, a well-trained and adequately paid workforce, reliable information on which to base decisions, policies, well-maintained facilities, logistics to deliver quality medicines and technologies. We need, people need to have access. There needs to be effective coverage. I'll talk about that. There need to be quality services and safety. All of these will help us get improved outcomes. We'll have a responsive health system, and people will have that social and financial risk protection that typically hinders people from accessing care. So financing and leadership are critical to all components of the health system. So bear this in mind as we go through the following, the next couple of slides. So this study, which is quite interesting, published in the Lancet about 2 years ago by Boerma and colleagues. It's an empirical data-driven study that used UN estimates for 151 countries to assess changes in maternal mortality, stillbirths, neonatal births over a 20-year period. On the basis of ratios of maternal to stillbirths, neonatal mortality, they identified 5 phases of transition, where phase 1 is the highest mortality and phase 5 is the lowest mortality. They use global databases to examine specific characteristics of causes of death, fertility rates, abortion policies, health workforce, financing, and socioeconomic indicators. And they analyze data from about 326 national surveys to assess service coverage and inequities across the transition phase. So what you have there, we'll not dwell too much on this slide, but just gives you an idea of the cutoffs for each one of these phases. So What you need to remember from here is that phase one is high mortality, whether you look at newborn indices or maternal indices. Phase five is where we would love to be, where mortality is quite low. Phase four will be somewhere around where most of the typical SDG targets will be. Okay, so just bear that in mind. Now, in a previous study, which was published around September 2014 or so, where they had proposed the first sort of obstetric transition model, and they did not include any neonatal cutoff points. One thing that came out from that observational study was that without improving the quality of care, you're unlikely to further reduce maternal mortality below 300 maternal deaths per 100,000 live births. So essentially, phase three. So let's look at some of the results, and I'll just summarize the results around health systems and service delivery. So health systems. Now, what they found out was that in terms of health expenditure was observed to increase from the phase of high mortality to low mortality. So countries where the health expenditure was low, they had the highest mortality, in other words. As a measure of access to care, out-of-pocket spending decreased with decreasing mortality. So in countries with the highest mortality, there was a lot of out-of-pocket spending. So where people have to pay to access healthcare services that risk them into going to financial hardship. So that's where we talk about out-of-pocket expenditure. Now, as you increase the healthcare worker density and skills mix, this was associated with a reduction in mortality, child mortality or maternal mortality. As you went from stage 3 down to stage 5, the preferred place of giving birth was in hospitals rather than health centers. And you can imagine, if you're in a hospital, you have all the resources, human resources, the supplies and all of that to deal with whatever emergency. And then you don't have to deal with delays in accessing treatment. So it makes logical sense. Now let's look at service delivery. In terms of service delivery, what worked was as you increase antenatal coverage, institutional beds, cesarean section and cesarean sections, and these were all observed with decreasing mortality. So there was higher coverage, 90% or more for antenatal care, higher institutional beds, higher cesarean section rates in stage 5, where you have the lowest mortality compared to stage 1, where you have the highest mortality. Hospital beds were also very important in lowering maternal mortality. Now, this one is interesting. So when we look at the issue of equity, so equity is very important. When we have aggregate indicators at national level, it hides a lot of inequities, which you will not appreciate. And if we just pick on one, looking at wealth centers. So institutional live birth coverage sort of, increased from phase 1 high mortality to phase 5. From phase 1 high mortality to phase 5 low mortality. But what was interesting is that equity gap between rich and poor narrows significantly from phase 3 and completely obliterates by stage 5. So increasing access in such a way that you address this gap is quite important. Unfortunately, this was not the case for cesarean sections. Increased cesarean sections, you see more in stage 5 low mortality, but that gap in rich and poor, the poorest households, was not lost. When you look at the total fertility rate, which refers to the average number of babies that a woman in a reproductive age will have during her lifetime. Now, this decreased significantly, about 6.1 in phase 1, high mortality, to less than 2, specifically 1.5 in phase 5, where you have low mortality. So I think some of the, just to summarize some of the key results and take homes for us. So on this slide, you can see that mortality cutoff points for each phase. But what is important is that in phase one, in the year 2000, you had only 21 countries. And in phase five, in the year 2000, you had 35 countries, 23% of all countries. In 2020, 5 countries only in phase one and 49 countries in phase five. So that increased. But what is quite relevant to us, we're in Nigeria now discussing, is that there are just 5 countries that were in phase one in 2020. And some of these countries were still in phase one in the year 2000. And unfortunately, Nigeria is one of them. So Chad, Central African Republic, Nigeria, Sierra Leone, and Somalia. So I think that's the key take-home message here in the interest of time. And then in conclusion, from this study, for the 116 countries in phase 1 to 5 in the year 2000, 73 of them progressed at least one phase between the year 2000 and 2020. 6 countries progressed 2 phases. These are Angola, Bangladesh, Ethiopia, Kazakhstan, Rwanda, and Tanzania. 3 countries regressed by one phase, the USA, Venezuela, and Vietnam. Nigeria was stagnant in phase one for over 20 years. This is quite depressing, but I mean, we just need to understand, what worked in those countries that made some progress. So declining proportion of deaths caused by infectious diseases and peripartum complications were associated with mortality reduction. Declining total and total fertility rates and adolescent fertility rates was associated with a reduction in mortality. Changes in health workforce densities and skills mix from phase 3, increasing per capita health spending and reducing out-of-pocket expenditure. These were the key things from this study that were associated with reduction in mortality. So before my child health colleagues accuse me of neglecting the child, if we look at the interagency report produced by the UN in 2024, you start seeing the importance of the social determinants of health. And if you look at certain things around household, mother's education, residence, birth order, birth interval, and mother's age, what can we learn from here? So to lower on the 5 mortality rate was associated with higher household wealth, higher mother's education, lower birth order less than the fourth birth intervals of more than 2 years, but not at age less than 20 or more than 40 to 49 years. Okay, so these are things we can learn, and we can factor this into how we design to move things forward. Clearly, the issue of where people reside, urban or rural, with mortality less in those who live in the urban, this will be a complex one. It may have to do with household income, access to healthcare facilities, paying for better quality services, and all of that. Of course, that will be associated with educational status, level of education, with women who have higher education having the least risk of their child dying under the age of 5. So these are things, that's why the social determinants of health, are quite important. We cannot disentangle from the complexity. Now, a quick one about Universal Health Coverage Index. So this measures 3 indices. 1, access to services. 2, financial risk protection. And 3, quality of services. And just a reminder, so SDG goal 3.8 is about achieving universal health coverage. Now, the Universal Health Coverage Index has increased steadily since the year 2001. And the cutoff where we have the current data is up to 2021. So the UHC index started plateauing maybe around 2018 globally and even in Africa. In Nigeria, it continued to rise until about 2019 and then started going down to 2021. So with the Nigerian figure at 38, Africa at 44, the world at 68. Again, if you look at where Nigeria stands, we are probably amongst the worst, the countries not doing well in terms of universal health index. And I think you can see that from this heat map as well. Where the darker color in pink there, or light brown, you can see that is where you have very low UHC index. Um, I mean, we can spend probably all of the time talking about the health workforce challenges, but these are global challenges. And just looking at, there's been a gradual increase in health workforce density over the since 2010. If we look at 5-year intervals, and in whether we're looking at low income, middle income, or high income countries for medical doctors or midwives, it's an upward trajectory, but the leap in low-income countries is a lot smaller. And, this is still a far cry from the kind of density we need to, cover our population, let alone those national disparities about urban and rural and all of that. But this is a big issue. So we have a big challenge with, first of all, we need to be able to train adequate numbers, recruit, deploy, retain them, and continue training them in order to get good quality of care. We will never be able to get, equal number of doctors and midwives. The midwives will always be a lot more. They are the forefront, and they need to be trained and deployed to the right places. They are the first line, they cannot not all sit in the urban centers. Women are still living and giving birth to children in the rural areas. So this is something to contend with. Now, a quick word about the whole concept of effective coverage. Effective coverage, refers to the proportion of that population that gets a positive health outcome. So everybody can be getting a service, but that health system is not really functional unless we are seeing improvements in health outcomes. And that is a factor of the content of the services provided, evidence-based practices, implemented to scale where women can access them and their families. So this whole concept of effective coverage, you can look at it as, you create a service for the entire population. Fewer members of that population will target a particular service. Fewer will get, that sort of combination of interventions that could potentially lead to an improvement in health outcome. And then by the time you get the number that actually have quality services that leads to an improvement in health outcomes, simply put, life or death, that number is smaller. So the take-home message here is that, you need to significantly increase the coverage to have that sort of measurable impact in terms of health outcomes and, the focus on quality. So I think in the last 2 years, through the Every Woman, Every Newborn, Everywhere initiative of the UN, they've set really bold coverage targets. Uh, so 90% of women receiving at least 4 antenatal care visits, 90% of women being seen by a skilled healthcare worker, 80% of mothers and their newborns receiving postnatal care within 2 days, and so forth. And they've created a dashboard where you can see, how each country is performing. And I just took this screenshot, from the dashboard. You can see where Nigeria stands. I mean, wherever you see red, it's not good. So acceleration is needed for all of our indicators. Those indicators where you see it's blue is because, the metrics they have used to make the conclusion, they've not applied that uniformly across all countries. Well, we've talked about maternal mortality. That's not too good. And for the last one that is blue, which is the proportion of newborns that are seen at postnatal care within 48 hours, there's no set sort of benchmark. So they have not measured. But I mean, the message here, all other coverage indicators is showing red. So that acceleration is needed. So quickly, let's pivot to health financing. And in 2001, African Union member states made a commitment in Abuja, the Abuja Declaration on Health, where AU member states agreed to allocate at least 15% of national budgets to health. If you look at data from 2025, only Botswana, Cape Verde, Rwanda have consistently met this target. Over 30 countries in Africa still remain far below 10%, with the median, just allocating only 7.4%. There is generally a decline in fiscal space, exacerbated by rising debt burdens, which impair the ability to increase domestic funding for health. Only 16 countries currently possess a national health development plan backed by financing blueprint. The AU has all sorts of systems and mechanisms to help countries develop these plans and proactively manage such plans, but the uptake of this support has been quite limited. So let's look at Nigeria. So again, disclaimer, all of this information I've just found publicly. So I'm happy to be told I'm completely wrong. But Nigeria has never met the Abuja Declaration of 15%. 2025, the federal government allocated 5.18% of the total budget to health. Although this is an improvement from 4.6 in 2024, it's still far short of what is expected. Some states, however, have allocated around that 15% that has been reported. So the highest allocation for health in Nigeria was 6.23% of national budget in 2012. But then there's another layer of challenge which is around budget utilization. So federal capital release into the health sector dropped from 96% in 2018 to 47% by Q3 of 2022. So late release, inability to absorb all the funds, and then the funds have to be returned and all of that. So inefficiency in managing these resources also cripples, the health system. Now, we all know what has happened this year with funding cuts from USAID. And the bottom line here is the funding from USAID really propped up a lot of the health systems in low resource countries. And it is expected that, the effect of this funding cuts, which we'll begin to see probably heavily in the next six months or so, will affect our ability to meet the SDG related targets, especially in child health. Now, interestingly, a lot of countries where you have the highest burden of mortality, child or maternal mortality, or whatever mortality indicator you look at, their sort of national health data management systems are weak. Civil and vital registration systems are quite weak. So they depend heavily on the DHS program for data collection, which is not prospective. The sample is retrospective. It's several years behind what the current situation is, but this is the best we have. Now, the sad news is that the funding cuts from the US government has impacted this program. So I think we really need to start thinking how we ensure that we have good data to help us proactively manage our health system going forward. Because the DHS, at least for the next 3 years, probably, it's not going to be there. Now, we just draw from a speech by the WHO Director General in his opening remarks to the African Health Sovereignty Summit in Accra, Ghana, 5th of August this year. And he really emphasized the need that we need to reduce our dependency on global aid, noting that uh, uh, health aid is projected to fall by up to 40% compared to 2 years ago. And this creates opportunity to end aid dependency. The effect of this funding cut, it's affect jobs, medications, people on life-saving HIV medications and so many other medications. All of these have been cut. We know that lots of people have died because of this sort of blow to the health system in many countries. Lots of countries, in smaller countries, they've really been hit where the workforce has been propped up by donor funding for up to even 50%, and this has had a huge impact. Domestic leadership and financing, we need to be able to increase domestic financing complemented by philanthropic funding. And, there are good examples from African countries with the Ghana Health Service, doing some, exciting things now. We need to increase the efficient use of resources. He noted that up to 13% of health budgets in LMICs go unspent due to weak public health financial systems. And I think I alluded to something like this previously. And WHO also has support systems which can help countries to improve efficient use of resources. But again, the optic of this is quite poor. There are structural constraints, debt service and donor bypass of health systems hinder long-term planning. And there's a need for global reform towards a fairer, more democratic, accountable global health architecture. Nigeria led recently a World Health Assembly resolution advocating for domestic investment and governance reforms. So in summary, child and maternal mortality in Nigeria is extremely high. Nigeria is unlikely to meet the MNCH SDG targets by 2030 without accelerated action. Health system approach is needed to address social determinants of health, reduce total fertility rate, address health workforce challenges, increase per capita health spending, reduce out-of-pocket expenditure, improve the quality of care and effective coverage of evidence-based intervention, strengthen national health data management system, and civil registration and vital statistics systems. And to mitigate the impact of foreign aids, we need to increase domestic financing, improve leadership, and improve our management of the scarce resources that are made available. So in conclusion, adequate health financing and management is critical for an effective and responsive health system. And drawing from some of the from the call to action by the WHO Director General recently, where he called for governments to invest in health and people, creditors to fair consensual lending. So this does not sort of hamstring countries to put all their resources in servicing debt, and then you cannot invest in health and in the people. Donors to strengthen national systems rather than create parallel ones. And at times, the donors are encouraged because leadership is weak. Health is an investment, not a cost. And the moment must be seized for transformation. So I thank you all for listening, and I look forward to the discussions. Thank you.
Great. Thank you very much, Professor Charles Ame. I think that is quite very, very helpful in terms of deepening our knowledge in terms of what is the global situation and what Nigeria can learn from it. It's actually very, very worrisome that Nigeria's progress has stagnated in the last 2 decades, where we remain in phase one of the grouping in terms of our progress. So thank you very much, Prof. So to our audience, please, if you have questions, please use the chat box to put your question, contribution in the chat box. I think the speaker will attend to them. So uh, moving from global thinking to local action now. So somebody in the room is saddled with responsibility of crashing maternal and child death in Nigeria. He has done great work in the past in his home state of Ondo State, but he's saddled with a bigger responsibility through a MAMI project now. So Dr. Dayo Adeyanju will be telling us, how does he want to do it? Looking at this huge challenge of maternal and child death in Nigeria. What is MAMI? You give us an overview of it, and what is different this time around. Dr. Dayo Adeyanju, over to you.
Thank you, Dr. Gafar. This is very interesting, and thank you, Prof. Ame, for the fantastic presentation. I think feel it's quite impressive, to listen, and it's clearly from what has worked in other countries. It's clear that the MAMI, that we are now that the country has adopted, as a strategy to crash maternal mortality, is the way to go. When you look at why Nigeria has stagnated, I think we need to start from there, is the fact that in the last 1 decade or two, you see the country approach to crashing maternal mortality as being silos. Every strategy that has been deployed, has looked at, the specific component of the drivers of maternal death. And for example, what I mean by that, when you look at the SOML, is look at putting commodity in the facility. The MSS, the midwifery scheme, also look at putting the midwife at the facility, which is looking at the facility component of it, as well as the chiefs. Also, the chiefs that try to look at the community component, didn't also look at the other component of other drivers of maternal death. So now what we are doing in MAMI, which is Maternal and the Newborn Mortality Reduction Innovation and Initiative, is basically to now adopt, knowing fully well that the Nigeria Health Sector Investment Renewal Initiative, look more, at using the sector-wide approach to drive the health sector strategic blueprint. And with this sector-wide approach lens is what we are now leveraging on or using to crash maternal mortality. Because we found out that in the last decade, maternal mortality has been oscillating between the 545, 576, and then 512, which is reduction. So crashing, like you rightly defined, mean we are aiming at going, below, all of this reduction. And so what we are doing differently, first, the innovation is to identify clearly where are these deaths occurring. And we found that they occur in 172 LGA, contributing 55% of our maternal mortality across 33 states of the country. And in this LGA, we are actually targeting 2.9 million women, pregnant women, having access, to care. And so why do women actually die? There are 5 delays, which has gone beyond the other delays we have known. Either people know 3 or first delay of seeking healthcare, the delay in reaching healthcare, the delay, in receiving healthcare, and then the delay, in referral or taking responsibility or accountability, and the last delay, which is the most critical delay actually, is what for the year longer while we are remain stagnated, actually alluded to, or which you have explicitly projected, is the fact there is no proper coordination across all of the interventions that were put in place. And so what MAMI is doing differently in our strategic framework is to now begin to look at all of the delays and look at strategy to counter them. First, we look at the delay in seeking healthcare, they need to have the community engagement. Having a clear community-based health worker, who can line list the women and then, of course, able to track them, and then linking them to a facility and then subsequently track their delivery. And then, of course, this community health worker also interface with the WDC structure, which is trending under the MAMI. And then, of course, the fact that, again, from there, we look at the access, which you have pointed to. There's a high out-of-pocket expenditure in Nigeria. So we try to look at, for every woman in need, which is what is responsible for most of maternal mortality, is the maternal and newborn emergencies. If we are able to respond to that, for example, a woman needs cesarean section, and she's able to, have unfettered access. And the president has been magnanimous to say that for every woman in need, cesarean section, shall be free. And they subsequently get enrolled into insurance, and that will cover the newborn. So that access is again covered. And, we also look at the access, physical access of ensuring that at that point in need, because most delivery happen in the middle of the night, is there a means of transportation? Also, we have set up a means of transportation across the MAMI LGA. We are actually working, we have been able to go through to around 15 of these states, out of the 33. And of course, like you rightly said, we are targeting at putting to scale. We want to ensure that we cover all of the 3 LGAs, in fact, including the non-MAMI LGAs, and again, to ensure that we have, the facility that is ready, either it's BMONC or CMONC, able to, provide a care and then counter the delay, the third delay of receiving health care. All of the things you mentioned, human resources, commodities, MSH commodities, equipment, and all of these, are things that we want to ensure. For a BMONC, they must be able to be at level 2 to perform the signal function, and for CMONC, they must be able to perform the 9 signal function. So these are things that we are trying to ensure, and there is a lot of support, working between the federal and the state, leveraging on the compact that was signed, between the federal government and then the state government, to be able to get this done. And then, of course, the other, the third thematic area here in Miami strategy framework is to create an enabling environment, meaning they deploy a digital platform to coordinate all of this, making it easy. The Nigerian Digital in Health are the ones that do with this responsibility, so that a woman, is being known to be high risk. Instantly, she put a call through. She's able to be linked to the emergency, the transportation, and she's able to be linked. Then the facilities are alerted ahead, and then she has access to free maternal, and then newborn care. So, and of course, lastly, in part of the enabler include incentives to make the woman to come come to deliver in the facility, which you mentioned. Increasing facility utilization or institutional delivery will definitely crash maternal mortality. And of course, reducing the out-of-pocket will also, lead to a crash in maternal mortality. So that's why I mentioned that most of the, those who are doing well, most of the things that are doing are things that we have adopted, in Miami, now. And lastly is the sector-wide coordination, management, and then coordination in line with the principle of the sector-wide, meaning we're now doing a one plan, we're doing one budget, we're doing one report, and then we're doing the one conversation and then one voice, between the federal, the state, and then the local government. We're also doing this across. So different agencies are saddled with the responsibility to be able to perform each of these thematic area across the MAMI strategic framework. You have the NPSCDA for the community. They've just signed an MOU with 10 states for the community-based, revised community-based health worker program. And the line listing, has been done across 7 states as well, which has brought to about 500,000 pregnant women out of the 2.59 million we are targeting. Yeah, and then also for the access, physical access, we have the NEMSAS in collaboration with the SEMSAS. That's the national, the Emergency Medical Services Agency with the state national emergency and then the state emergency services. They are working together, and they have been able to set up, in this MAMI LGA, in collaboration with either the NURT or deploy tricycle ambulances or using their own ambulances. And in 14 states, there is onboarding, and in fact, as we speak today, they've done over 4,000. It's just this week that we started this. Over 4,000 women have been transported, responding to the emergencies and, having access to safe delivery. So also, we also have the Federal Ministry of Health and, the National Primary Care leading in terms of the digital, and then data. And this is training the MPCDSR, to ensure that for every unfortunate, maternal death, it is actually reported, reviewed, and then there's a quick response. And also, in terms of the facility readiness, we have the National Primary Care working with the state primary care to get the BMONC, to be ready to be all at L2 functionality, and then the CMONC, we're working with the state, the swap office working with the state to get the CMONC also, to be able to perform the nice signal function. And so with all of this, we are tracking, the data. We have a sector-wide approach, RAMCA scorecard now, which is looking at all the indices, from NC1 to NC4, to ensure that, we are able, to track every, maternal
Okay,
death and
Dr.
then understanding of
Dr.
that.
Adeju, let me interject here. Thank you very much. I think it's quite interesting that you have put a lot of mechanism in place that aligns with the global best practices in terms of what we can do differently. I can see part of what you are trying to do differently is to means of targeting to identify where are the women dying, identifying those women, and then of course deploying the digital innovation, leveraging sector-wide approach, and of course working effectively with the state and others. I think this is very impressive. Later I'll come back to you to look at
Right.
what are the anticipated. I'll come back to you later to look at what are the anticipated challenges. But let me quickly go to the Honorable Commissioner for Health, Ekiti State, who is the chair forum of commissioner. So, Honorable Commissioner, in recent time, when the NDHS 2023 result came out, I'm very sure you are one of the happiest commissioners in Nigeria because Ekiti State actually did very well, made progress on a number of indicators. So we want to find out from you, what did you do differently in terms of governance, financing, service delivery that actually took you there, that you are able to move the needle? And what can the nation learn from you as we are attempting to crash the maternal and child death? Over to you, Honorable Commissioner.
Thank you very much, first, for inviting me, and I think it's a pleasure to be here to share our experience from Ekiti. I resumed in August 2020, and I recall that in the first 1 month, one of the first things we did was to have a retreat with the entire sector. The idea behind that retreat was to ensure that we agreed towards a common vision and a plan to achieve that vision. And that's what we followed over the last 5 years as a state. And the first instance, to address some of the challenges around inputs, we were very focused on the things that mattered. So we looked at our health workers. We recognized that even though we didn't have enough, and our fiscal space wasn't necessarily robust at the time to get more, but it was important that we upskilled those who were currently available. So we focused very heavily on training, IMCI, BMONG training, to improve the capacity of the health workers that were available. We recognized as well that having the health workers was not enough. It was also important that we had the drugs available in the facility and they were of good quality and constantly ready to be delivered to the patient. So we backed our warehouse with a bill, and we then set up a drug management agency that allowed us to procure directly from manufacturers, guaranteeing quality of the commodities that we're having, but also helping us to reduce the cost of those commodities and pass the savings to the facility, to the patients. Having sorted that out, we then address the financing side, which is the point you made. And this is something I'm always proud to speak about, which is our Ulera flagship health insurance program. And the idea behind that was to focus on what mattered. In Ekiti, 73% of the reasons why people go to a facility or want to seek care can be addressed in a primary health center. And so we covered all of that, package of services within that 73%. And it's largely around family planning, it's antenatal, it's delivery, it's routine immunization, it's malaria for everyone, it's ensuring that people receive postnatal care, right? And so we backed that up with funding. We trained our health workers. We communicated and continue to communicate to the public around our Ulera program. And I'm happy to say that everybody in Ekiti, as of today, over 700,000 people have utilized the service, but everybody in the state is actually covered for Ulera program. On the governance side, having addressed the supply conversations, I talked about the inputs, focused on the financing through Ulera. We also then realized that it was important that we paid attention to what was going on. And what we did was to set up what we call the interface, which allowed me in my capacity as the commissioner to sit down with not just the heads of the agencies, but also the directors. And we did this every single week. We'll sit down, we're looking into the data, asking tough questions. Of course, as always, these things don't, and at the outset, it wasn't something that everybody really bought into. But when they began to see that what it did was create a sense of accountability, there was a lot of transparency around it. People saw that they could leverage on what other players within the space were also doing. People became more, interested in getting this going. And so at any of our interface meetings, we sit down and we're looking at the data. What are the issues? How do we trash them out? Where are we seeing results? And what can we learn from the results that we're seeing? And we repeated this process as a cycle every single week. So the head of SPHCDA, the head of insurance, the head of the hospital management board, the staff from the ministry, or even the teaching hospital, everybody sits down together to really address the challenges. And there were things that I need to escalate. I sit down with His Excellency, my boss, to make sure that we're able to sort them out, whether it was a funding issue or just some additional knotty issues that needed to be addressed. If there are things that needed to be escalated or to be addressed at the agency level, we found a way to address that. If it was a community conversation, speaking to either the religious leaders or the traditional rulers or whoever needed to be spoken to. So this tripartite combination, right, where we focused on the inputs to improve them, ensured that we addressed a key driver of lack of access through the Ulera program, and where I sat down with the team to pay core attention to the data that was coming in and addressing the issues, really helped us to turn things around. And that's why when the NDHS came out and the results were seen, we saw that we had crashed our neonatal mortality by 57%, from 42 per thousand to 18 per thousand, and crashed our under 5 mortality by 54% from 95 per thousand to 44 per thousand. Thank you.
Okay, thank you very much, Honorable Commissioner. I think this is quite impressive how you have deployed the whole system approach where you look at identifying issues, human resource for health, drug supply, and use of data, especially using data to coordinate the sector, because part of the problem you see in many states is that Ministry of Health is on its own, primary care board is on its own, and drug agencies on its own, and they are hardly coordinated. I think it's quite very, very impressive using the data to effectively coordinate. And I will come back to you again because now, all these things that you've said, I want to find out as a chair of the commissioners forum, how do you ensure diffusion of those practices to your colleagues? I'll come back to you in a minute, but let me quickly go to Dr. Funke Fasha, where she leads a Clinton Health Access Initiative in Nigeria that has been doing a very, very great job in terms of in area of maternal and child health. And Funke, I want to find out from you, whether we like it or not, partners are part of success story in most of the states in Nigeria. So from your experience, you have implemented a wide array of program. What are those key lessons that we've learned that we should scale if we really, really want to crash maternal and child death in Nigeria from child's experience? Over to you, Funke.
Thank you so much, Dr. Gafar. And I must say that, to be honest, I think between Professor Ame, the Honorable Commissioner of Ekiti, and also Dr. Dayo, they've addressed pretty much everything that we've seen from experience. Chai has been working in the maternal newborn health space since 2014. I would actually say as far back as 2012 from the London Family Planning Summit, and then we went into the broader MNH space. And one of the things we've done is really try to demonstrate models that can help address the high maternal mortality in a context like ours, where you still have very high home delivery rates. I mean, in some states in Nigeria, almost 95% of women are still delivering outside of a health facility. You still have issues with inadequate healthcare workers. You have, it's not just that they are not trained, but you don't even have enough nurses, you don't have enough midwives. You have significant challenges with access. So when I talk about access, I'm talking transportation, I'm talking about road networks. And so there are just a myriad of issues that really make it so difficult and challenging. And, you know, riding on what we've already heard, one of the things we as Chai have really been pushing, and we've demonstrated working in Kano, Kaduna, and Katsina, covering all the LGs and over more than 10 million people, is you'd need an integrated / comprehensive approach to tackle maternal mortality. You know, when we came into the space, we found through a lot of our research and analysis that prior interventions were focused on one mortality driver. So you would see an intervention that is only looking at, oh, let's crash postpartum hemorrhage, or let's crash preeclampsia, or let's focus on, you know, asphyxia in babies. And the question then you ask is, what about all the other potential complications that contribute to the high maternal mortality? Granted, it's a handful of complications that drive mortality. But for us, what we've learned is that 24 to 48-hour window is the most critical period in a mom's life, right? Any type of complication can arise. And unfortunately, whether you're delivering in America, you're delivering in Australia, you're delivering in Ekiti State, all pregnant women have a similar 15 to 20% chance of developing complications. And so what is critical for every pregnancy is that at the point of delivery, you want to make sure that there is a birth attendant who is appropriately trained, skilled, and supported. And I would emphasize support, because it's not enough to train health workers and not equip them with the commodities that they need or with the devices that they would require. So whether it's having a suction device to be able to clear the nose of the newborn, whether it's having an ultrasound to be able to check, for example, in prolonged labor to understand, you know, the positioning of the baby, and whether it's having oxytocin, heat stable carbitocin, different innovations that have now come out that are helping to save lives all over the world, right? So it's really important that you have these birth attendants that are appropriately skilled, knowledgeable, and they are equipped and supported. But more also important is that you have a consistent availability of those commodities, those supplies. You also need to ensure that there's a referral system, right? So with maternal and newborn mortality, it's not, you just provide antiretrovirals at a certain point, people come there, or vaccines where you go into communities. In the case of maternal mortality, the complication can take different forms. And so what you want to be able to do is manage, stabilize, and refer where you're not able to actually cure or treat the condition. And so referrals are extremely important, being able to link across different levels of the healthcare system, from primary to secondary to tertiary. I would also like to re-emphasize this issue of data. We've heard it time and time again, data, data, data. We can't get away from improving our maternal and newborn health data in Nigeria. What we've learned is we need to be able to track every pregnancy, understand those mortality drivers, and tailor solutions to where we're seeing pockets of high mortality and what the commonest issues are in those communities. It's not a one size fits all. The issues are not homogeneous. What is killing moms in certain local governments is very different from what kills moms in others. For example, you might be surprised to hear that anemia is much higher in certain parts of Nigeria, and it's a big reason why we see high cases of PPH. In other parts of Nigeria, it's quality of care, right? In the eastern part, where we have much lower mortality rates, quality of care is a big issue because, people are dying due to errors by the health workers and the rest, or even the quality of the commodities that are being utilized. And I'll just wrap up to say the other critical factors, which we've heard, governance is extremely important. I think management capacity at all levels, not just at the commissioner level, but all the way down to facilities, equipping frontline health workers to think like first responders, to understand the data and to be able to use that to improve the performance of their healthcare system. That's one of the things the emotive trial showed, that management capacity is critical. And finally is sustainable financing. And, this particular webinar is talking about financing. Someone has to pay for it. Someone has to continue to pay for it. And we have to figure out how we can pay for all of this. Thank you.
So thank you very much, Dr. Funke. I think you mentioned a number of very, very important points that we have to take into consideration. One is about the scope of intervention. So we're looking at one aspect of intervention is very, very important to bring everything together as much as possible. And you mentioned looking at critical period, critical window between 24 hours, especially just before delivery, and immediately after delivery. I think our intervention now have to be very potent around that period. Of course, our ability to use data and identify different people in different areas. Try as much as possible, of course, not forgetting the issue of sustainable financing. For that sustainable financing conversation, I would like to go to Sachin, because Sachin, UNICEF recently looking at child health intervention, financing child health intervention. UNICEF has been able to incorporate this intervention to the existing financing mechanism of government. In Yobe State, you are able to integrate child health intervention around immunization to the state health insurance scheme. Recently, you look at analyzing the public expenditure review and all those. So from all these interventions, Sachin, what lessons has UNICEF learned that will help us in terms that scalable lesson that we can use to do things differently in terms of sustainable financing for child health and by extension, maternal health as well. Sachin, over to you.
Okay. Thank you very much, Dr. Ghaffar, and thank you very much for all the members as a panelist. The discussion are very interesting and very important in terms of the overall health financing landscape at the country. So in terms of UNICEF, we started developing our health financing portfolio, very focused health financing portfolio from last 2.5 years, and we are very deliberate towards contributing, to the landscape, particularly for child health, as we think this is a key foundation for overall health systems. So this has not been about a quick fixes. It is all about, laying the foundation for a sustainable, equitable health systems that works for every child, regardless of where they are born or their families. So our overall strategy has four main components. First is like, we have a separate work stream called public finance for every child, under which we are working closely with the federal and state government to make sure children are not invisible in the budget plan. This means producing the child focused budget briefs that clearly shows where money is going, where are the gaps exist, and how spending could be more efficient. We engage deeply during the budget cycle, including the midterm expenditure framework discussion to push for higher allocation to health, education, and social protection. We call this approach as a public finance for every child. So second strategy is mainly providing the technical assistance on health financing related activities at state and federal level. That's particularly costing of the primary healthcare services packages, analyzing the equity to see which groups are being left behind, assess the efficiency and understand how money can go further to map the financing gaps in areas like immunization. Third, we are supporting the sustainable immunization financing and procurement. For decades, UNICEF has been trusted partner in vaccine procurement and delivery. But our work is not just about the securing the vaccines today. We are working hand in hand with the government to develop financing pathways so that the cost of immunization can be gradually absorbed into the national and state budget over time. This is a critical because immunization is one of the most cost-effective investment in health, and losing momentum due to funding gaps would be, uh, you know, very tricky and tragedy. We cannot afford it. And the last but not the least, the expanding the access through integrated health insurance intervention. As Dr. Banji also mentioned, like, health insurance is the key vehicle to actually improve the access and also reduce the financial barriers. So UNICEF is supporting the health insurance agency in selected state, particularly, targeted intervention, which is mainly targeting the vulnerable communities, particularly those communities with high number of zero dose children. This the particular intervention also trying to be as a catalyst to activate the state equity fund, ensuring that the most marginalized population can get the care they need without paying out of pocket at the point of service. It is it is a practical way to translate the principle of the equity into action. So these are our main four strategies which we are working with the states and also federal government. What are the lesson we mainly learned with these strategies? So as we also had a very good experience from the equity state, so we also learned that the government ownership is essential. So any financing reform that are designed and led by the government rather than externally driven are far more likely to last. Early engagement of the state and federal authorities as a genuine co-owner of the process makes all the difference in the sustainability, as we have experience from our PHC MOUs, where in a program design we always have a counterpart funding component where we are trying to have the ownership with the government, and which was really gave us a very good experience and the ownership and sustainability over the period. Then also the evidence changes the conversation. That is also one of the very important lesson learned that we have, particularly when we are having the discussions with the policymaker, and uh, when we are presenting them a look, some evidences, and using those evidences to effect the policies, that also give us a very very good you know uh, mileage in terms of having that critical conversation and having that advocacy to increase the funding, to increase the interest into that particular areas where nobody can shy away and neglect those areas. So again, as my fellow panelist also mentioned about the domestic financing. So our through PHCMO, we were able to increase the domestic financing in the multiple states, and that is also one of the lesson learned, where the ownership and advocacy can increase, the overall system can be strengthened, and the the health can be a high level political issue where the government can really wanted to come ahead and put the investment into the health. So integration into the broader financing systems is also one of the lesson learned, where embedding child health into the state health insurance schemes and equity funds makes financing more predictable and less vulnerable to the end of the donor projects. So that is also our one of the major lesson learned. And as mentioned by many panelists, the sustainability is built step by steps. The most successful reforms start small, targeting high-end areas, and the scale up based on the evidences with a clear plan for the government to take over financing over time. So these are our, key lesson learned, and also the strategies that we are working with all the states. And so far, it's working well. Particularly, we were able to ensure the ownership, sustainability, and able to create that interest. Particularly, health can be seen as a high political issue, and the more focus and the prioritization for child health can be done. Yeah, over to you, Dr. Gafar. Thank you.
Okay, thank you very much, Sachin. I think there are some things that we have to take note and scale based on important lessons that you've shared. I think the issue of paying attention to public financing, which is very crucial for sustainability. We are talking about how you have done the, analytics in terms of analyzing what is the public expenditure, how much is being spent, what is the money buying, what is the efficiency of spending. I think that is going to be very, very critical. And the technical assistance you talk about in terms of building the capacity of government agencies to be able to, budget, execute efficiently, and track themselves, use their ability of them to use their own data, and promoting government ownership. I think that's very, very key. Thank you very much, Sachin. I'll still come back to you because we must have encountered some challenges which you tell us and how you think we can overcome them. So the engagement of the civil society is a very crucial for a number of things, for advocacy, for accountability, to ensure that things are implemented as planned. Government is held accountable for spending, but not only spending, but spending well. And that is where the civil society is very, very crucial. And we are very happy to have in-house Chief Mojima Kajola, who is the chair of Nigerian USC Forum, a body that's an assemblage of non-state actors that are committed to putting Nigeria on the universal health coverage trajectory. So, Chief Mojima Kajola, if I may ask you, as the you had a damning verdict that says Nigeria has highest a number of maternalities. And not only that, Professor Charles Ame has told us in the last 20 years, we had not made significant progress because we are still in the phase one of the maternal deaths ranking. So what has this, how responsive has been the civic space in terms of society? What have the society been doing to ensure we change this narrative? Chief Mojima Kajol.
Thank you very much, Dr. Alawade, and a very good afternoon to all participants, particularly our keynote address speaker who gave us an in-depth into where we are and where we should be, and of course, other members of the panel. Yes. How has the Nigerian civil space, in terms of advocacy on reducing maternal and child health deaths? First, I'd like to come up with this: every mother deserves to live through childbirth. Every child deserves to see their 5th birthday and more. And that's why we're here today. So I'm very excited to be part of this. So now let's go back to your question, Dr. Alawade, on the question of how active the Nigerian civil space has been in reducing maternal and child health, reducing mortality around that space. First, I'd like to say that the Nigerian civil space has been vibrant, strategic, and increasingly united. You recall that just before this administration came on board, we had, it's a coalition of us and minds that came together to say, okay, let's have the Nigerian UHC forum. At that point, we even we termed it UHC 2023 Three, yeah, hoping that that will at least give enough loud voice to ensure that the voice of Nigerians are heard, particularly taking advantage of the electioneering campaign, ensuring that indeed the voices of Nigerians are heard. Also, the UHC forum which I chair today came in to be that voice that will push for advocacy. And we were all over the place for every of the space or platforms that were created to promote healthcare and make healthcare one of the priority areas. Because oftentimes politicians, you and I know, would tell you that they'll build hospitals, they'll do that. A lot of them, we found out themselves, don't even know how the health system works. So that helped us so that we can put health on, the top of the political agenda. We just didn't stop there because if people don't even know what to ask, they are satisfied with a lot of these facilities, hospitals and all that littered all over the place and not in use. So we embarked on what we call citizen engagement. It became very central to us because why? The people themselves must understand what the system is all about so that they can make demands from the point of knowledge and also amplify their voices so that the level of engagement would ensure that everyone is on one page. And this level of engagement has earned us recognition as a civil society movement committed to policy advocacy and implementations. Now, we follow through a lot of these policies that oftentimes pronouncements are made, but what about implementation? So turning health policies into real impact, leveraging our wide network to promote transparency and accountability in the health sector. Well, this has given us recognition as a partner in progress with the Federal Minister of Health, and the coordinating minister actually acknowledged this because we just didn't stop at speaking to people to understand. We also engaged the coordinating minister ab initio. Once he assumed office, we ensured that we engaged with him so that together we also can be seen as partners and solution drivers. Oftentimes, people complain and they don't come out with solutions. And of course, until you hear from people themselves, you really don't know what suits who. And I'm happy that a lot of us have confirmed, that have spoken, that one cap does not fit all. So ensuring that the peculiarity of each intervention suits wherever that intervention is going. Now, again, through feedback mechanism, which we have embarked on, we ensure social accountability mechanism are being strengthened through feedback systems that ensure citizens' voices influence decisions. We ensure that people can track commitments, monitor service delivery, and hold leaders to their promises. Nigerians are now emboldened to ask or to speak out where facilities are, not functional, or where facilities are doing well. They actually come out themselves to say, "You go here, you be there," and mentioning names. I mean, we've been around and we've seen the glory of what that has given us today. Like we have our most important, well, one of our most important guests on the panel today, Dr. Filani, who I'm sure the fact that people are beginning to speak out and implementation is being given some measure of accountability has earned him continuously to hold the positions, to hold the position which is holding today. And we found that using one of our strongest partners and constituency, the media, to amplify the voices of communities, mobilizing both individual and collective action towards reducing maternal and child mortality. We're not there yet, and so our work is not done. And but we have consistently amplified community voices through the media, encouraging both individual and collective action to reduce maternal and child mortality. We use every opportunity, from media programs programs, and some of us here have been on some of these programs to amplify what is available, to also ask for individual and citizens' responsibilities going forward in promoting or reducing, or as this seminar is addressing, financing maternal and child death, crashing crashing the death rate, for which none of us here, I'm sure, is happy about. So we use every spotlight to address this urgency, pushing forward. And so we find out that the non-state actors, or the CSOs, have now become greater partners, not just in terms of criticism, but in terms of seeing themselves too as partnership and as a deliberate group of individuals that can make health work. So, but we are speaking to health financing, as it were, as it affects what we are doing today. There's still plenty of room to ensure that the non-state actors understand where we're going. We see knowledge gap in some areas, and until, of course, we are able to bridge this gap, so that we can all speak with one voice, so that we don't have silos all over the place. The coalition that is coming forward now, coming together of the non-state actors, non-governmental organizations, and all that. And we also have been leading in the discussion for the aftermath of these low funding coming from donors. These are some of the things that we've done, and we are still doing, hoping that we can, as a people, change from where we are yesterday, but be proactive ourselves, to be able to ask questions, to make demands from the point of knowledge and understanding, and be able together to ensure that we can move the intervention forward. I'm sure more questions, well, I still have one more question. I don't know if Dr. Gafar wants to ask now, according to the lineup you sent to me. But I think that we must now encourage community ownership of health financing. Thank God that the National Health Insurance Agency has come up with a vulnerable landmark for people who are vulnerable to be able to secure some measure of health financing. I think a non-state actor want to pursue vigorously going forward, because this will help. Because oftentimes the delays, well, one of the delays that we found out is that out of pocket, a lot of, people, mostly women, are so vulnerable that they cannot afford, to pay as at the time they seek for health. So we'll continue with this conversation. I'll stop for now, and thank you for listening.
So thank you very much, Chief Mojima Kajola. Of course, a number of important things that Nigerian UAC Forum has done and is doing that we have to pay attention to it, and look at possibility of scaling. One is to consider the issue because the issue of financing health could be more political than technical. How the Nigerian UAC Forum has, like Antimoji has said, engaged the political class before the election. And part of the problem in Nigeria is that health has not been on the agenda during the election. So Nigerian Youth Forum attempted that. Probably you build on that in 2023. The issue of working closely with the governments, setting the agenda together, making input to the policy forum that actually make the Honorable Minister identify Nigerian Youth Forum as a partner. And of course, the issue of effective engagement of the media and listening to the citizen to get their feedback and use that, and the civil society serving as a conduit between the citizen and the government in terms of influencing policy. Thank you very much. So let me quickly go back to before I ask Professor Charles Amin around the issue of international diffusion of best practices. Let me quickly go back to Dr. Dayo Adeyanju. Of course, you gave us a very exciting picture of the design of the MAMI. It includes a number of things that we have not been taken into consideration in the past. So, Dr. Dai, I want to find out from you, what are those challenges that you anticipate in the implementation of these? and how can we mitigate? How can we work together towards because the issue of financing is still there. It's not very clear in terms of how much does will it cost to crash Mami, for example? Where would the money come from? How do we ensure efficient utilization of these resources? These are what are those challenges that you anticipate, and how do you want to overcome them? Dr. Adeyanju.
Okay, so thank you very much. It's the Mami, implementation has been very interesting, I must say, because we have to co-create, with the state from the federal. We go to state like 14 states we have been to, 15 states that we have been able to activate clear action plan to them. We do this, meeting with the state, with this, establishing a state Mami task force, and then having a clear coordination and management structure, at the state. But what is more important is that, so what we do is facilitate how all of this intervention are retrofixed into the annual operation plan. And one of the critical thing is then, like Professor Ame mentioned, is wanting to now have it in the AOP in the budget, was another thing to have the release. So one of the major challenge is having the fund, to be released, for implementation. So having done this, for example, we went to Kano, in January, so the progress have not been much, even though yes, they pick some of this and then they're able to implement. But so when we realized it, so what we have done is to then say, what are the critical things to really save the life of a woman? We come up with the minimum viable product, and then we try to identify at least one or two facility, and then the CMON can panel for cesarean section, and then have a community-based health workers who can create demand for those services. And then, so what is to say that for all after we do the plan, we do the costing of the plan, with the states love to do it by themselves, and they know what is retrofix, what are the gaps. So it is from this gap that we, then try to see how to now mobilize resources, either from the development partners group, and we also try from the federal, from National Primary Health Care, the NEMSAS, as well as the NHIA, and then, of course, from the swap office, we try to see how to support this, prime the situation for the state to now be able to release, their own, because that's the only way you can ensure sustainability. The insurance actually is the way to go, because it's the way to ensure that for every woman after delivery, or even prior to delivery, they are covered. Because so if you have a clear number of deliveries per year, what the cost, looks like, you can tweak, and look at what the premium, looks like for sustainable financing for this. Because we do not want it to be partner driven. We want a clear, government-led, program, particularly state government, to take ownership. And then, so what swap tries to do is to just facilitate the collaboration between the state and the federal, as well as the partner, and then, of course, getting the community buy-in. Getting away from the financing challenges, one other critical challenge is actually the competition between the facility, and, the traditional birth attendant, mission birth attendant. And we are also trying to work on how we can then identify these TBA, mission home attendants, get them, to be able to collaborate with them to identify, to be able to understand the danger signs, refer our patients. We do not want to give room for delivery, because oftentimes people don't know how to their limit. So this is actually a very serious one because there's so much emotional attachment to TBA. But we are looking at, the strategy that is best, one that I adopted while as commissioner in Ondo State, coupled with other best practices, is to see how we can engage the TBA. Then third piece is a lot of sociocultural, barrier, and religious barrier also. Situation which affect the seeking behavior. And I tell you, for free that, and it varies in different parts of the country, and that's why you see a lot of home deliveries, people trying to demonstrate their own cultural belief that a strong Kanuri woman will not go to the facility to deliver, and then try to deliver at home, and in the process they lose their lives. So all of this, are one of those key ones that we have found, So we now try to get the WDC strengthened, restructured, and more functional, to respond to the mobilization of this. Yes, everybody has alluded to the fact that data is a problem. So what we're doing at the moment, is that we also the verge of just hosting the dashboard where we can just be tracking all the data across the country and then be able to respond during our MAMI coordination meeting, either the national, and then giving the feedback to the state MAMI task force to be able to coordinate. And then those one can also go down to the World Development Committee level, to see how, situation, can get better, either as a result of low NC, or low facility delivery, care. But one thing that I must say is that we are, as much as possible, trying to integrate SRH, into our MAMI program to ensure there is uptake of family planning, because we do not want to encourage, people from not having right family sizing or spacing. So these are issues, that these ones have come so clear. So as a result of this, we are now engaging more stakeholders, like getting, the spouses of NGF, getting NGF, to be able to help us, flag this during the Nigerian Governors Forum meeting, and then getting the spouses of the governors to also help in the mobilization across the state, across, the spouses, of the chair of the local government council, and then working together, town hall meeting with the religious leader, traditional ruler, and all of these are ways we're trying to circumvent. The president actually have actually gotten a $1.5 billion dollar to be Hope Project Fund to really strengthen and then promote equality across, which was the World Bank support. And through this, we try to incentivize some disbursement linked indicators, which will ensure that the states are able to have access, to more funds to be invested. In fact, they even have opportunity for advances. We know we know this is what you're likely going to be able to meet, achieve. We can then give you some advances in form of 30% to support the state, to be able to get their facility ready in the process of meeting with the minimum viable, product. So all of these are things actually that we're doing to mitigate some of these challenges. And then we hope, the trend is actually getting interesting and impressive. We do hope, in the next couple of months, we will begin to have a clear change in the narratives of Nigeria being the workspace to deliver. Thank you.
Okay, thank you very much. I'll be very excited if there is that changing narrative, as you rightly mentioned. You mentioned a number of challenges, how to raise domestic financing for this is extremely important. You talk about the issue of getting the buy-in of the governors, and of course service integration, and many other important things that we should pay attention to in terms of for these crashing maternal child death to be a reality. Let me quickly go to the Honorable Commissioner. Somebody said we should give the Honorable Commissioner half of the accolade he deserves because he wear two hats as he's the Commissioner for Health in Ekiti. On that aspect, he has done very well. Now, as the chair of the forum of the commissioner, so somebody said we should give him the half of the accolade if he has to be able to translate what he has done very well in Ekiti to other states as the chair of the forum of commissioners. So on a serious note, Honorable Commissioner, all these important things that you have achieved the best practices as the chair of the forum of the Commissioner for Health, how do we replicate these in other states so that will make progress? Honorable Commissioner.
Thank you very much. First, let me say that the Forum of Commissioners, it's a relatively young forum, started, if I do recall correctly, in 2017, 2018. So it's about 7 years. I'm number 4 in terms of the chairperson. We've had 3 of my ex-colleagues who had led it. But at the outset, when it started off as an organization that, brought colleagues together to have a conversation with federal, right? Particularly at the time, SOML challenges, and to ensure that, a minister could reach out to states. One of the things we've done very well over the last 3 years, where I've now led the process, is to move away from it appearing to be a pressure group, but to ensure that we have a system that allows us to learn from one another, right? So cross-collaborative learning, opportunities for engagement, either state to state or even just peer learning across board. And I think we've done quite a bit of that over the last 3.5 years. We've gotten, and I'll give a couple of examples in this regard. 2 years ago, we had what we call the Vision Alignment Program that we did, supported by one of our partners at the time, ensuring that what I had described that we're doing in Ekiti in terms of the interface, every state could focus on that. So how can a state focus on a common vision, recognizing that every different agency has a role to play? The SPHCD has a role, the insurance has a role, drug management, HMB has a role, but really it's one health system. It may have different levels, and everybody must understand that we all have a role to play. So we had that, and that is going on in some form. Taking away from that, we're seeing learnings across states. I give an example of the Know Your Number, Control Your Number campaign that we ran last year with over 1.5 million Nigerians tested for non-communicable diseases, hypertension and diabetes. With that, we're thankful to Ishino, who had helped to pull all this together in terms of the data. But now we have the policy briefs for all states. We have the opportunity we've created registers for all states, and the goal is to take this forward. And so the point with this is we're seeing elements of what is happening in Ekiti State, and not just even in Ekiti, in some of the states who are doing really well. Jigawa as an example, Ogun, Gombe, Yobe, Lagos, the different places, Rivers, Abia, right? All that means states doing different things where there are opportunities for colleagues to learn from. And that's really for us now as a forum, the core focus is how can we use this forum to learn from one another? And a very clear example is the drug management agencies that have been set up. In 2020, there were only 6 states that had drug management agencies. As I speak to you now, there are 29 states that have their drug management agencies set up and backed by law, and a number of them are now procuring directly from manufacturers. We've done that direct procurement from manufacturers for a while, and now we're moving towards how do we pool all of this procurement across states together so that we can better negotiate and better engage manufacturers in a win-to-win situation. Win for states in the sense that we can look for lowest pricing across, but more importantly, also it guarantees a consistent level of funding for the manufacturers, particularly at the beginning of the year, when once the quantification is done, they're able to use that to plan accordingly. So this is one example. There are many more examples of how we're doing this, but progress is slow. And I think this is something that is always important to put on the table. Unfortunately, we're not going to see a maternal mortality turnaround in 2 months. It's highly unlikely to happen. Progress is slow. What matters is that it is steady, it is consistent, and that those who are in place of authority, i.e. my colleagues or the agencies, have a very clear laser focus on looking at that data and using that data to address actions and turning those actions into meaningful implementation on the field. Thank you.
Okay, great. Thank you very much, Honorable Commissioner. It is heartwarming to know that your platform is serving as a peer-reviewed mechanism. You are actually bringing evidence together in terms of policy brief, which is influencing action and decision by your colleagues. And I get your point around being laser focused on use of data for decision making. So, Dr. Funke Fashawe, uh, from your experience, from what we have learned, from what we have had so far, how will you advise our stakeholders from policymakers, partners like you? What should we be, civil society and other, what should we be doing differently if we really want to change the narrative? Because I don't want to come back here to 5 years after we are still talking about these a very, very troubling, narrative. What should we do differently?
Well, a few things. I think first and foremost is, especially for us partners and civil society, is to align with government's priorities. I think that's really crucial, right? And so I'll tie that to the whole concept, which the sector-wide approach is aiming to achieve, which is coordination. We really need to coordinate. There's too much where we're duplicating efforts, we're reinventing the wheel. And this goes even to government. Government themselves, you entertain different partners, different agendas, even when you know that you've done something before that works, right? So I think that the very first starting point is for all of us as stakeholders to really coordinate against one plan. What's the government's vision? What does the government want to achieve? Understand what our individual roles and responsibilities are. What are the strengths we bring to the table and how can we advance that? Yes, government wants to do a lot of things. They don't always have the capacity to do everything. They may not always have the funding to do everything. I mean, we heard about some of the ideas around the commissioners forum, and some of the challenges with really being able to move things along, right? So of course, support would be required, but we have to be supporting in line with what has been set as the broader vision, the broader goal. I think secondly, let's just be very honest with ourselves. One of the things I struggle with in our health sector is we don't like to be accountable. We talk a lot about accountability, but we stakeholders are not very accountable. And to be accountable starts with transparency. We really need to interrogate data. We need to create a culture where we don't see data as blaming people, as reporting ourselves, but really data as something that makes us better off in the long run. I've seen too many times, without mentioning specific examples, where we see bad data, there's an assessment, the data is not good, and we bury that information. We don't discuss it, we don't share it. We only want to come out and say Nigeria is the first country to do this. Nigeria is the biggest population. Nigeria was the first to write a policy that never gets implemented. So I really want to charge us as stakeholders to be more open. We need to create a data-driven culture, a culture that looks at, we're inquisitive about data. We want to understand why the data is telling us what it's telling us, and change the narrative based on data, not based on what we wish it could be, aspirational. And we should just tell ourselves the truth. We're not telling ourselves the truth. We don't tell ourselves the truth. You go to many meetings and people just want to talk about what was working and not really deal with the crucial issues. The third thing I would like to say is we should think about the role of technology, digital technology. There's an opportunity now in this day of artificial intelligence to really take advantage of digital. But of course, we can't do digital if we don't have the right data. So in line with some of the efforts of MAMI, as soon as we start to generate this data, how can we also layer on technology and use that to support more women, to reach more communities, and even to support our frontline healthcare workers who are extremely strained and stressed because they are not enough. There's a lot of work and they are not adequately funded to do that work. So I'll stop here because we could go on and on, but I think these three critical things would really help us move things forward. Thank you.
So thank you very much, Funke. I think those are indeed very, very, very critical and very, very powerful. You talk about alignment. And I get your point. So when we're talking about alignment, even when we're talking about MAMI as an initiative, even within the government cycle, are they seeing it as an integrated initiative, or is the initiative of Dr. Adeyanju and MAMI and the swap office? I think that is very, very critical for all. Before we even talk about partners aligning, we have all the government agencies at the national and subnational level. We need that alignment, which I think is happening, but more of it needs to happen. You talk about accountability. To stress your point around accountability. When the whole report of that says Nigeria is now has the highest maternal, I expected a lot of outcry in country. I never got that. I think your point is very, very important in terms of we don't need to bury bad data. We need to discuss it and take a decision and the use of our technology. On that note, I will go to Professor Ahmed because he started this conversation around the use of technology. Professor Charles Ahmed, uh, so you've seen what many countries, what they do, and that we are in the era of technology. What's your advice in terms of how, and we have to be very careful with technology itself. What's your advice in terms of how to adopt technology, and what do you see as a barrier to diffusion of a best practice from international to national level, and what should we do? Prof, over to you.
Thank you very much. Can you hear me?
Louder.
Yes, so thank you so much. It's been really a great learning experience just listening to all the speakers. I think some of the key things where we need to leverage technology, which will really help us in terms of the quality we're looking for, accountability, better management of our resources, will be in the area of the financing, health education of people in the community. They said knowledge is power. People need to. When I was working clinically in Nigeria, I mean, a woman comes to the antenatal clinic with a scar on her abdomen, and you ask her, why did you have the C-section? And she says the doctor said so. She doesn't have any idea. You ask the doctor, okay, why didn't you explain to this woman why she needed this? And he says they will not understand. So we've gone beyond that now. People should be able to ask for their information. The information is theirs, and use that to advocate for good quality care. And technology provides us with that opportunity. Medical records, so lots of insights from various speakers from Ekiti State, from what they're trying to introduce in MAMI. The quality of our medical records is very poor. Health care workers are overstretched and burdened. Supporting parallel health information systems by partners. I've been to a primary healthcare facility in Nigeria where they were up to 18 different registers, different partners asking this two-woman clinic to complete all of this. And at times they even incentivize them. And when you look at the standard Ministry of Health register, there are huge gaps. Because, I mean, they need to split their time between completing registers, providing good quality care, having some more incentive for their pocket. So, I mean, all ridiculous. So if we have, a very clean system, it's electronic, can be transmitted in real time, it is complete, that can help us in decision making, and technology can help us do that. Factor in some AI, like the last speaker has said. I mean, we have to move with the time. We can use AI to simplify a lot of things, help us, improve the quality of our management. Supply chain management, very important. And I think good examples have been given. The commissioner spoke a lot about this. Blood transfusion services. With good electronic digital systems, digital technology, you can really improve blood transfusion services. You have blood banks that are empty. There is no blood. You cannot replace if you need blood, you need blood. IV fluid is not blood. Red blood cells carry oxygen, which is, if it's needed, is needed. We should be able to get this going. This will help save lives. So I'm glad to hear that MAMI will provide funding for free cesarean sections, and when needed, that's great. But with free cesarean sections, you should have enough doctors, enough operating rooms, stocked blood banks, IC units for backup, all of that. By the time you need a C-section, anything can go wrong. You need all the ancillary services for the woman to go in and come out. Digital technology can also be deployed for healthcare worker training and certification. So we need to think critically. Gone are the days when there was so much money in the system. You train healthcare workers, take them away from healthcare facilities for so long, so many days, put them in hotels, pay them lots of DSA and all of that. There's no time for all of that. We don't have enough healthcare workers. The more you take them away, the more women will die. We've seen in advanced countries that people can do self-directed learning, and then you focus short period of time for where you need hands-on learning. So we need to rethink all of this, and the digital technology is there to help us. Colleagues have spoke brilliantly about the opportunities for digital technology to improve accountability. I think that we can really embrace that and take that on board. And I'm really excited around, what is happening, different states, moving forward in improving the quality of health. And I hope that other states can be challenged, and key stakeholders, civil society can, challenge in their state to say, look, the other state is doing this and they are moving forward. What are we doing in our state? The press can come in to help to drive that accountability. And finally, referral systems. We need good quality referral system, where a woman needs help. I know with the MAMI, I've heard about that concept already. Dayo talked about it, but she needs, for example, and there's a scheme like this in Lesotho, which I saw, Partners in Health. What they have funded is a call center. It's all integrated into the government thing. There's a mobile app, and they're using a sort of Uber-like service to transfer women to a hospital, and then people get paid through their mobile phones. But first, women have to be triaged through a central service that has experienced and care providers. They can triage and see which is most important, which is the nearest driver, deploy and refer, and track this with data. To see what impact this is making. So there are lots of innovative things that are happening either in Nigeria or within Africa that we can adopt and scale up. The question is, how do people know about these things? How people know, what is working, what is good practice, what is evidence-based, and how to scale it up. I don't expect the policymakers to go and read the journals and all of that. So how do we make that connection so that, we invest the scarce resources in what is likely to work? And then we have the culture, like colleague said, the other panelist said, where, accountability is a watchword. We use data to drive change. And, we don't become defensive. We have to just put a mirror in front of ourselves and say, you know what, enough is enough. We can make a difference. The physiology of a woman in Nigeria is not different from a woman in Spain or in the UK or in Lesotho. It's the same thing. So if women are not dying there, some of these countries are not better resourced than Nigeria. So we should really challenge ourselves. Nigerians are leading good service delivery, good healthcare, good management in several places in the world. Definitely, we can do it in our own country. And I think the momentum has started. I just want to encourage all of us that I strongly believe we can do it. It's not impossible. We need that good leadership. We can use the resources we have better. We can, become more accountable, embrace digital technology, embrace change. Change management is critical. Accountability is critical. Our health system is complex. There are nuances in different areas, like have been mentioned. And, we should know that, yes, people talk about emotive study and everybody's shouting about it, but this was an experimental setting. If you don't replicate exactly what was done, you may not see the results. So that's just an example. We just need to be careful and understand how we can replicate things to get results. And if it's not working, we should not wait till 3 years. In 6 months' time, we should know it's not working because we can see the data. And how do we course correct? That is the attitude that I think will bring about change. Thank you.
So thank you very much, Professor Charles. You've mentioned a number of things, especially around use of digital technology, which are very, very important, from use of AI, use of technology for other areas as well. And but you mentioned something extremely important, that we should invest on what is likely to work, and we should pay attention to use of evidence and leadership accountability, very, very important. So because our time is fast spent, we'll only take a couple of questions and contribution from a participant. There's a question for Dr. Dio, which say, let me read the question. It says, considering the adoption of SWAP, how are we bridging the gap between academia, program implementation to translate evidence-based context-specific strategy into maternal and child a program like MAMI and ensuring coordination? I think the centrality of the question is around how do we bridge the gap between the academia and the implementation actors so that we are evidence driven. Dr. Dayo, do you want to quickly answer that?
Okay, so thank you very much. I saw the question, but one of the critical components of SWAP is the implementation research or operational research, as the case may be. And so for this, we actually have been in talk with the academic, to see how we align in terms of our implementation research, operational research, to use it as for our evidence-based, decision, making. And of course, some quite a number of these are ongoing, even though yes, they are yet to be, be completed. So, for example, of course, we also started talk with Nyson, Pan, Sogon, and to see how, we can collaborate together, because there's in fact, one of the critical challenge I didn't mention is the issue around the human resources. We are looking at how we can collaborate, to actually bridge the human resources gap. So actually, for us, in SWAP and for the MAMI, all of the data analytics, all of the our interventions, are evidence, driven. Even when we go to the field, like when we were in Kaduna, we had the like of Professor what's her name now, who is a renowned academic, that we were
Professor Clara Ejembe.
Ejembe, yes, Ejembe. In Kano, where with Professor Galadanchi, who provided us with the SFAP, research, that they did to inform some of the decisions. And in fact, when we go to the field, it was quite useful, in terms of drivers of maternal mortality, having do a lot of verbal and social autopsy. So that's actually the kind of linkage. Even same for Kaduna, and also when we're in Ogun State. For all the states we've been to, we actually be getting the academic, to be part of the discussion and conversation. In fact, the last 4 states we went, we had all the PAN member and the NASO member as part of the people who went to the various communities to do deep dive, and understanding, what are clear drivers of maternal mortality, analyzing the data, and then using that to inform a clear decision on which intervention is best, for this the state. And this is what we put in all our MAMI implementation, plan or roadmap, which is costed, and then for the state, to put in their annual operation plan, and then we try to see how we supported that. That's
so Dr. Dayo, thank you very much. We are very excited to know that, of course, we are bridging the gap between the academia and the implementation actor. This is quite impressive. So, so there's a question around which I would like Dr. Funke to answer. So there's a question from one of our we received earlier on that, okay, Professor Charles has made a presentation
Only
on
50 left.
part of drivers for crashing
Mm,
maternal death is use of more of a multisectorial action where we promote education of women and look at other social determinants of crashing maternal. In your own opinion, how do we integrate it? We have been singing about multisectorial action all this while. How do we translate it to action?
Maybe the Honorable Commissioner would have been best placed to address this, but I think it starts with patient literacy. And Professor Ahmed did allude to that in his comments. I think we really need to invest a bit more in educating the communities, educating the women. Let women better understand their health. Let's understand the process of pregnancy, the potential outcomes, what you need to do, and really take more ownership of our own health. Everything from nutrition and how that impacts pregnancy and pregnancy outcomes, to water and sanitation, all of that right from the community level will go a long way. Of course, if you take the socio-ecological model to think through this, right? So you start with the individual, you empower them with their health literacy, and then you have to think at a community level, what are the issues? Of course, one of the big issues is the issue of gender in our own context in Nigeria. Gender and how that intersects with all of our sociocultural behaviors and our beliefs. And so I think, again, that community engagement is critical, really addressing the root causes that affect, women being able to access healthcare on time and some of the delays that Dr. Dayo spoke about. If you then take that forward to beyond the community, so you start to think about whether local government or state level is taking what someone like Dr. Banji has done in the health sector and extending that beyond the health sector. Can we see a time where in state executive council meetings, they start to talk about healthcare indicators? So it's not just a health sector issue, but the governor himself, the executive governor of that state, really highlights the issues about maternal mortality, newborn mortality. And once you see that level of leadership and that discourse, it starts to force the women affairs, the water department, the education to talk to each other. Because we also know that one of the factors, one of the predictors of poor maternal outcomes is also education, right? So educational level, all of those things, right? So I think state level, you really need to have that high level of leadership and ownership, not just within the health sector, but really have the governors take lead. And tied to that, I would say one of the things we're learning more and more is we assume that our politicians understand healthcare the way we do. And maybe that's one of the failures of our public health approach over the years. I've learned myself that we really need to invest in educating legislature. We have to really teach them about health. We feel as healthcare people that once you say, oh, every day a plane load of women are dying, that it evokes the same sentiments and the same reaction amongst the legislators. But that's not the case. And I'm sure Dr. Gafar, you know this very well. So one has to really invest in bringing the politicians along, making them appreciate the importance and the impacts that this is having on everything, the economy, the productivity, and even just the societal costs of losing every mother that we lose or every newborn that we lose. And similarly at the national level, I think we can't get away from that high level leadership at across board and facilitating more intersectoral engagement. Finally, I would say, I would think the honorable minister, the honorable coordinating minister will have to extend, and I know that some of that is happening with the education department already, but he really does need to extend that beyond health and invite all these other honorable ministers to the table and to come together and figure out what a lasting solution to our maternal mortality issues are. Thank you so much, Dr. Gafar, and everyone
Thank you
for
very
this
much,
opportunity.
Dr. Funke. That is very, very helpful. You did a justice to that question. So, unfortunately, we will not be able to take more questions or contribution. Our time is fast spent, but of course, there's a justification for the times that we have spent because we discussed something very, very important. We started with the global perspective in terms of what have we learned from other countries that have made progress in terms of crashing maternal and child deaths, in terms of how they invested in system service delivery, financing, human resources, and others. Of course, we look at a very, very good opportunity that we have that what Nigerian government is doing around crashing maternal and child health. The MAMI initiative, unique in many ways in the sense that it's targeting where the deaths are happening, they're following the women, they're using technology, and they are bringing everybody together. Of course, it's not without challenges as well. And we have seen island of success stories in Nigeria as well. We have seen the case of Ekiti State in terms of the progress they've made, the lessons we've learned them, the importance of leadership, the importance of a strong intersectoral coordination. We have seen that. And we have seen the opportunity to scale all these using the platform Nigerian Commissioners Forum. We've seen the great work that we have done. We have seen what partners have done in terms of using the scope of intervention, in terms of leveraging accountability, leadership, and others. And we have seen, especially in the area of health financing, what other partners are doing in terms of promoting public financing for health, which is very, very critical if we are going to achieve the sustainability we are talking about. We have seen how they are building the capacity to improve health financing, allocation, execution as well. And again, we have seen how partners initiatives are being integrated into existing government financing mechanism like health insurance. But I've also seen how the civil society have played a very, very important role in terms of putting health on the political front burner, taking advantage of election, engaging the policymaker, bringing citizen perspective into policy making. We have seen all those as well. And we have seen the role of technology, and the guiding principle here is that we have to be very selective and look at technology that will help us to make a progress. So on this note, I would like to thank our speakers from Professor Charles Ahmed, the Honorable Commissioner, Dr. Dayo Adeyanju, then Funke of Chai, Sachin, UNICEF, and Mommy in the house, the head advocate #1, especially among women in Nigeria, Chief Mojima Kanjola, the chair of Nigerian USC Forum, for the invaluable contribution to these. And of course, we thank all the participants, more than 150 that joined at a point or the other, that contributed one way or the other, asked questions and contribute to the discourse. On our part as a DJI Consult team, of course, we are trying to produce knowledge products from these policy brief and even publishable material from this, so that it does not just end as a talk show. So we're able to translate knowledge to action. So I thank all the speakers. I thank the participants. I thank my team at DJI Consult as well. I would like to appreciate your contribution, and I hope when next we organize another health policy forum, you will join us because I'm very sure there is always something to learn from this conversation. So on this note, I thank once again. I cannot thank our panelists and speakers enough. Thanks for your time, and I wish you enjoy the rest of your day, and I'm very sure that all of us will be part of a crashing maternal and child death in Nigeria. Thank you. God bless.